Good morning. Are you not seeing me? Well, good morning, everybody. I just had Dr. Rosensweet. I believe I will have him again, unless maybe you guys are having him again. I'm not sure. Gonna wait just a second and see what happens. I guess. In the meantime, there he is. Can you hear me?
We've got an echo.
Okay. So let me quickly then start with the first question and say good morning. Yeah?
Okay, good morning, Carolyn. Yeah.
Good morning. First question comes in, Dr. Rosensweet, and welcome everybody.
I wonder why we have the echo.
Daryl's working on it. I'm on.
You have two microphones on?
No, I just have live stream, and I'll lose you if I get that gone. And I have our Gmail, and I am so sorry. Go away. Ugh.
Maybe your cat is also asking the questions and giving an introduction as well. Maybe that's what the echo is.
I think he's mad at me because he can't. Not sure. Please excuse the cat. It's a part of my back. Let's see if we can try and do this anyway. Let me get started with the first question on mute. Dr. Rosensweet, does low or high progesterone contribute to a hot flash? I do know that estrogen, high or low, can definitely give hot flashes, but I'm wondering about progesterone only. Dr. Rosensweet's comment last interview mentioned that progesterone can bind to estrogen receptor sites. Does this mean that it then blocks the estrogen from getting into the receptor, therefore into the body?
Wow, our questions are getting more and more technical. And yes, it's a good question. And what it comes down to is that if a woman takes too much progesterone, she can get a hot flash. And that can be confusing. And then the question is, what constitutes too much? Yesterday, this question came up in our grand rounds, and there was one provider that if she takes 150 milligrams of progesterone, she'll get a hot flash. That's unusual because 200 milligrams.
I can't hear you and you're frozen.
Wow. Hopefully it's going to work. I'm going to pick up where I left off there. So part of it is how much constitutes too much. And the average in my practice of women who take oral progesterone, for example, we always start with topical progesterone. Some women switch to the oral progesterone. The average is, well, the range is somewhere between 150 and 150 milligrams. That's common. So our healthcare provider, a medical doctor in menopause, who takes 150 milligrams and gets a hot flash, that's rather unusual for 150 milligrams. Let me give you the theory of it, and I think we did cover this a little bit last time. when you think of a hormone, you think of the hormone, and then how the hormone actually works is there's this receptor site inside inside the cell nucleus. And the hormone comes in and links up with that receptor site, and it's that union that causes the effects of the hormone to begin. That's what promotes it. And then the hormone does the things, and it comes out of the receptor site. Actually goes to the liver, actually gets metabolized, excreted, and new hormones come in. And there's different types of receptor sites. There's two types of estrogen receptor sites at least. There's progesterone receptor sites. There's thyroid receptor sites. There's cortisol receptor sites. This is how hormones work. Testosterone.
You're frozen again.
I think you can get. Trying it again. It turns out receptor sites are pretty specific. So when a receptor site has a name, it's not the name that's significant, called an estrogen receptor site, it favors connection with estrogen. However, it's not the only thing that can activate that receptor site. Like, well, estrogen binds most effectively and most voraciously, I was about to say most lovingly, to the estrogen receptor site. But progesterone also will bind to an estrogen receptor site. Not as strongly, not as avidly, not as passionately as an estrogen molecule will, but progesterone will bind to an estrogen receptor site. That's almost inconsequential under ordinary circumstances, except if there's an overabundance of progesterone molecules that, by a specific law of chemistry called the law of chemical mass action, when there's way too much of a certain molecule, what will happen is the progesterone will start binding to the estrogen receptor site. And if there's way too much progesterone, it'll even push any estrogen that's in the receptor site out of the receptor site. This is how we believe that a woman who takes too much progesterone gets a hot flash. She knocks her estrogen out of the receptor site. And so she gets a functional, effectively a functional estrogen deficiency symptom called a hot flash. That is not the only mechanism. And this one is more obscure, and this relates really to too little progesterone. What I just described relates to too much progesterone. It's known that some women who are in the perimenopause or early menopause who are having hot flashes can alleviate and hot flashes are primarily triggered by low estrogen. Yet some of those women in perimenopause and early menopause can alleviate. Here's the exquisite interaction. I'm going to have to talk.
You're frozen again. Uh-oh.
And we're back.
And we're back.
I'm going to have to talk to the director of the interweb.
Oh my God, ladies, your patience is amazing. We are trying so hard here, and neither of us have a clue why this is happening, because it doesn't happen other than with us. But Dr. R will be back. I know it. So in the meantime, we're talking about having hot flashes from too much progesterone. And I know that Dr. R is making his way back to us, but the question came in, does low or high progesterone contribute to a hot flash? And he's trying to explain this. So I'm hoping that he's going to reappear magically. And again, I appreciate your patience. One way or another, this is going to be fixed because this is a little odd. Whew. I may have to leave here.
And I'm back. So I was talking about low progesterone and hot flashes. And there's some women in the perimenopause who are having hot flashes, even though that's an estrogen deficiency symptom, that if they take progesterone, hot flashes will go away. Not common, but it does work. And this is this exquisite interaction of these hormones. The orchestration is, I can't even get my mind around it. Progesterone facilitates the function of estrogen in the estrogen receptor sites. So that's alleviating hot flashes with progesterone. Now, just to keep it simple, ultimately, the goal in replenishing hormones in women is to get the right amount of estrogen, the right estrogens biased, the right amount of progesterone in the right form, the right amount of testosterone and DHEA, and very often attend to thyroid as well, for each individual woman. Now, every woman's need for estrogen varies from one woman to the next. For example, one woman can do fabulous when she's young, menstruate, be fertile, get pregnant, at one level of estrogen. And for another woman, the range is so wide that it can take 3 times the amount of estrogen for a second woman to be normal in her body. 3 times the amount. They're both normal. They both can be regularly menstruating, ovulating, fertile, get pregnant, etc., carry to term pregnancy. That's how wide the range is of one individual to the next. So this is not a problem in any way, really. I mean, we address every single woman in menopause the exact same way. We individualize. We learn a lot of information about each individual woman, choose from a variety of choices about what the proper starting program is. Start at low doses, gradually increase. And we're playing independent variables there. We're working with estrogen independently, progesterone independently, testosterone independently, and usually we just combine DHA with testosterone. So it's not a problem, the individualization, at all for anyone who takes the time and has the commitment and has the willingness to learn about how to treat women properly, how to treat women expertly with these most powerful biochemicals that we have, these hormones, replenish them at midlife. Now, back to the question was, can too much progesterone cause hot flashes? Yes, by pushing estrogen out of the receptor sites by the law of mass action. I can't give you a number, though. Some women need 300 milligrams of progesterone to do well. And they're not going to get the estrogen pushed out because they're also going to be simultaneously be treated with estrogen. And then the lowest number I've heard for actually a woman getting a hot flash who was being treated with progesterone was 150, and I mentioned that earlier. But don't think about the numbers. A proper hormone discovery program is going to get you there. And that whole rare, I say it's rare, a woman getting a hot flash from progesterone, that event, that'll be sorted out by someone who knows what they're doing. So no fears.
It's pretty fascinating that we're all women. You guys are all men, but we are so individual, and I know that you as a doctor see that all the time, have seen that all the time. I won't go into the story, but it had to do with, I believe, thyroid, and you talking with a doctor and figuring out how to dose a woman with thyroid. It's a good story. Maybe we'll bring that up next time. Thank you very much for that answer. Yeah. I'm going to ask this quickly from Jan. She says, postmenopausally, how effective is estriol in the protection of bones, brain, and heart?
Well, I love this question because a young woman's ovaries produces 3 active estrogens, not just one. So the word estrogen is really about a family of hormones. And the 3 active estrogens is estradiol. That's the most potent of the estrogens that a woman's ovary produces. And a woman's ovary also produces estrone. That's about 80% as potent in its effect on receptor sites as estradiol is. And estrone is about twice as prevalent in a young woman's body, even a little more than twice as prevalent as estradiol. Estradiol is always considered to be the principal estrogen in that it is the most potent, but it's not even the most prevalent. And there's a third active estrogen. Its name is estriol. And that's what this questioner Jan is asking about. And estriol turns out to be more prevalent. There's more estriol coming out of a young woman's ovary than there is the sum of estrone and estradiol. Must be a reason for it. Nature, quote, nature seems to think that estriol must have a function. Estriol is not as strong or as potent as estradiol. It's about 1/8 as potent as estradiol, but it's again more prevalent than the sum of estrone and estradiol. The average prevalence, because this has been studied by 24-hour urine hormone testing in the late 1960s by an oncologist at the University of Nebraska who did 24-hour urines on young healthy women. And he's the one who came up with this discovery that estriol is more prevalent than the sum of estrone and estradiol. As an average, it's 1.3 times as prevalent as the sum of estrone and estradiol. We call estrone and estradiol the most potent estrogens, and the sum of them, and we call the total potent estrogens. And when you put up a math equation and you put estriol, the amount of estriol in a 24-hour urine, in the numerator, bringing y'all back to your mathematical heritage.
Ew.
Numerator. Oh, Carolyn says. You put the amount of estradiol in the numerator in a 24-hour urine, and you put the sum of estrone and estradiol in the denominator, average is discovered by Dr. Lemon on 24-hour urine hormone tests of young, healthy women in the late 1960s. That average is 1.3. So there's 1.3 times as much on the average of estradiol as there's the sum of estrone and estradiol. I know I'm repeating myself here, but I want this one to sink in for you all. This is prior to understanding what the function of estradiol is. It's just it's more prevalent than the sum of estrone and estradiol in young women. Interestingly enough, for reasons I won't go into right now, I was funded to do a study in 2000 and about 14 or so by a very prominent American functional medicine lab, Metametrics, to do a study of young, healthy women, to repeat it. The work of Dr. Lemon, and I did. And young, healthy women, that was a challenge. Someone who was regularly menstruating. We interviewed 600 nursing students around the United States. They were the ones most motivated to collect urine for 24 hours, most interested in the topic. And we were able to get 99 specimens out of 600. So
wow.
Healthy. And these young women, bless their hearts, were stressed. I have special, deep respect for any woman entering the nursing profession.
Oh, no doubt.
The process itself of education is a mite stressful, shall we say. But anyway, I've got 1.1. Dr. Lemon in the late 60s got 1.3 times as much estradiol as the sum of estrone and estradiol. I got 1.1. Now, what Dr. Lemon really did, why he was interested in this, is he was an oncologist. And he wanted to see if there was any relationship of hormones to breast cancer risk. And he found a difference in that ratio called the estrogen quotient. In young, healthy women had an average estrogen quotient of 1.3, and women who had breast cancer, when their urine was tested, they had a lot less estriol. It was lower, much lower than 1, much lower than 1.3. There's a very big difference there.
Wow.
Lemon proposed that one way we could assess for women as it related to breast cancer was to do 24-hour urines and get that estrogen quotient. And if it was way less than 1, these women were more at risk. Now, just as an aside, the causes of cancer or any illness are multiple, thousands and thousands of adverse events from the time we're born to the time we develop a significant diagnosis. Issues of problems in nutrition and toxic exposure, issues in too little or too much exercise. And the elephant in the room affects the immune system, the whole body, is stress, a dysfunctional response to the stresses of life. These are the causes of illness, plus a fifth cause called mysterious. Some people, we just never explain how they got serious illness. And that's very important to know that, because you don't want to judge yourself for getting a serious illness. Sometimes we just can't figure it out using common assessment methods of this particular lifetime. We don't have ways to assess the health of the eternal soul yet. We're not drawing blood on the eternal soul of somebody. So back to the question, because this all got stimulated by a question. What about estradiol? So the medical doctor, beloved father of, so to speak, of bioidentical hormones in the United States, along with Jim Hernser, bless Jim's heart.
Oh, yes.
Jim's had a monumental event take place in his and our love is with him and his family. He lost a beloved relative.
Prayers up.
Recently. Jim simultaneously and Jonathan, living in different parts of the country and not aware of one another, in the early 1980s, came up with the idea of bioidentical hormones. Up till that time, the vast, vast majority of the 18 million women who were being treated in menopause with hormones were being treated by horse urine-derived estrogens and estrogen products. Well, Dr. Wright and Jim knew that pharmaceutical manufacturers also produced a very pure, molecularly identical, bioidentical hormone. They had pure estrogens, they had pure testosterone, pure progesterone, same molecules what a woman's ovary put out or a man's testicle put out. And Dr. Wright proposed that his compounding pharmacists go get that stuff and put it up in creams and gels, get the pure molecule. Thus were born bioidentical hormones. Well, Jim Herntzer, a compounding pharmacist in the Dallas area, did the same thing. He said, God, I can get a hold of pure bioidentical estrogens. I'm going to get them and put them up in a cream and gel. Apply them topically. It's the safest way to go. Thus, the birth of compounded bioidentical hormones. Not exactly. The Chinese figured this out 1,000 years ago. They collected the urine of young, healthy women in one container and young, healthy men in a different container, dried that urine out, and there's some pure bioidentical hormones, and the aristocrats had access to that and took that stuff. The birth of bioidentical hormones as we know it, at least as we know the history of it. This is 1,000 years ago.
It's fascinating, really, to me.
Yeah. So what do you find in the urine of a young, healthy woman? You find more estriol than you have the sum of estrone and estradiol. And Dr. Wright proposed that why not have his compounding pharmacy make up a triest, do the same thing that a young woman's has present in her body. And that's what the pharmacist did. The pharmacist made up a combination of a cream that had estriol, estrone, and estradiol in it. Very quickly, because Dr. Wright also had an exquisite 24-hour urine hormone lab. He has a lab that does a lot more than that. But because he had that 24-hour urine hormone lab, he quickly learned that the estrone was not needed, that you just give a woman estradiol and estriol, and she's going to produce and replicate youthful patterns of the estrogen family and the metabolites. Thus, Biest was born in the 1980s. And Biest is a combination of estriol and estradiol. And you go to a significant number of healthcare providers that have gotten education and favor compounded bioidentical hormones and treatment with it. A significant number of them, a significant percentage, are going to be treating with Biest. In fact, we respect estriol so much that the common starting formulation is 80% estriol and 20% estradiol. And most of the time, that's going to mimic urinary patterns that have the same relative amounts of estriol, estrone, and estradiol that a young, healthy woman does. In other words, as Dr. Wright originally languaged it, copy nature, folks. Don't try and reinvent the hormone patterns of a young woman or a male or female. Just copy nature, as he so famously said and repeats year after year after year. Now, lo and behold, when Dr. Lemon did that original study of breast cancer patients and healthy young women, and Dr. Wright and Jim Herntzer invented the popular and the treatment. Well, they didn't invent it; they reinvented it from the Chinese, but invented compounded bioidentical hormones and treatment with Biest, for example. There was no knowledge about the estrogen receptor site. And in the late 1990s, lo and behold, there's a discovery of the molecular structure of two estrogen receptor sites, estrogen receptor site alpha and estrogen receptor site beta. And these are extremely active in every young menstruating woman. They're all over the body. They're present everywhere. They're present in the female organs. They're present in the brain. They're present in the brain. Did I say they were present in the brain? Oh, yes, I think I did say.
I think you said brain. Yeah.
I think I said they're present in the brain, estrogen receptor sites. And here's how they work. After menstruation, a whole physiologic, anatomic process takes place in which a woman prepares for a possible fertilization. And in that first half of the cycle, there's stimulated by hormones, stimulated by estrogen, for example, there's the formation of the lining of the endometrium, a rich, rich lining capable of receiving a fertilized egg and implanting in that rich, rich lining. So estrogen really affects the formation of the endometrial lining. Well, that's not the only effect of that first half of the cycle. Believe it or not, this is staggering to me. Every single month, in possible anticipation of fertilization, a woman prepares for breastfeeding. She actually forms new breast glandular cells by a process called cell division, otherwise known as mitosis. Many women experience this as their breasts become fuller after they've menstruated. Throughout the cycle, the breasts become fuller. Well, part of that fullness is the addition of new cells in preparation for possible implantation of a fertilized ovum. And if that there is implantation in that rich uterine lining of a fertilized ovum, the whole process just carries on for 9 months until, and I'm not going to go there. If there is not implantation, once a month, this whole thing is reversed. Eventually, by day 28, most commonly, that fresh, new, richly vascularized endometrial lining is going to slough by a process known as menstruation. And what looks like bleeding is actually an endometrial lining that has a lot of blood in it. So there's blood, it appears like blood. There's other stuff in there, there's tissue in there as well. And once a month, these new cells that formed in the breasts by cell division, by mitosis, additional breast glandular cells, once a month, since there was no pregnancy and there was no need to prepare for breastfeeding, these cells disappear.
Right.
By a process, I always thought this was just wonderfully just named, by cellular apoptosis. These new
favorite word.
Yeah, these new cells, they disappear once a month. Jan Rosen might wonder why this lengthy explanation. Because here's why. The proliferative phase of the endometrium and the proliferative phase of the breast glandular cell division and new cell proliferation is under the guidance, under the inspiration of the action of estrogen on estrogen receptor site alpha. And should there be no impregnation, the deproliferative phase, including the deproliferative phase of what took place in the breast, the apoptosis phase, is under the inspiration and guidance of estrogen receptor site beta. I'm getting there. And this is why doctors and patients are called patients. Patients are called patients, but doctors are called patients too. We have to be patient. And the chief estrogen that stimulates estrogen receptor site alpha is, drumroll, estradiol, the most potent of the estrogens. That's the one that is the principal stimulator of proliferation that takes place in the uterus and takes place in the breast. Excuse me. And the chief stimulator of the deproliferative phase is estriol. The chief stimulator of estrogen receptor site beta is estriol. One could see the value of deproliferation every cycle, and one could see the value, if for no reason at all, of including estriol in any estrogen treatment program. And if you just think about it for a moment, why did Dr. Lemon find that in women who had breast cancer, they had a lot less estriol? They had a lot less deproliferation. Hi, Marita. Yes, that is amazing.
It is amazing.
No, it's just boggling. You want to, if those of you who wonder whether there's a divine, just dive into the subject of medicine. And I can't tell you how many religious experiences I had in medical school. So I started seeing what's going on. Oh my God.
Small side note. There used to be a show called Voyage to the Bottom of the Sea or something, and then they did an offshoot, but it was a movie, and they put people in these capsules that went through the body, and they were I don't know if you remember that name. I can't find it, but they were getting, shot at by the white blood cells, and they were going around. It was a fascinating movie. If I can find the name, I will, and I'll put it out there. Maybe we can find it. It's really a great movie. But go ahead.
So that's why we make such a case for treating women in menopause utilizing a robust amount of estriol. We want deproliferation. We don't think it's such a great idea for a midlife woman, or man for that matter, to get cellular proliferation with mitosis. Mitosis is a very vulnerable moment for the genes in the history of the cell, and doesn't matter if there's a mutation, a healthy immune system is going to pick up that aberrant cell. Oh, but what do you know? Midlife, do we have the same vigor of immune systems that we had when we were younger in our 20s? No. So in a desire to create the absolute optimal, most healthy program for treating women with hormones in menopause, I am a very, very passionate advocate of using estriol. And the initial bias that we prescribe to a woman is 80% estriol and 20% estradiol, for the very reasons that I described. We want to emphasize deproliferation. Sometimes we'll change that ratio of 80-20, but only after we've looked at a 24-hour urine hormone test. And that subject would be getting into too much depth, why we would change that ratio from 80-20. And I recommend that no woman be treated with anything less than 80-20 unless her provider has done a 24-hour urine hormone test on her while she's being treated and seen that, oh, she could use a little more estradiol. But if that's not seen on a 24-hour urine hormone test, and that does show up, when that happens, it doesn't happen that commonly, that should be the reason to vary from the 80-20, in my best opinionated opinion. I'm highly opinionated.
That non-humble opinion of yours?
Yes, that non-humble opinion. Now, having said all that background, the question was really about, how about the bones, the brain, and the heart? Well, estrogens are extraordinarily protective of the arteries. And the arteries to the heart matter, just like arteries to the big toe matter, or to the little baby toe for that matter. All the arteries matter. And the arteries to the heart really matter, because you get decreased circulation to the heart, you got some big issues going. And the heart arteries are very vulnerable to arterial sclerosis for a special reason. They got high hose pressure going on in there. The pressure inside those coronary arteries is they're the very first arteries to leave the heart. They're under high pressure there, so they get some, just picture a fire hose aimed at a wall. You're getting your highest pressure in these coronary arteries, and they're very subject to injury. And the injury of import is arterial sclerosis. And we know this about young women. They have less risk than young men. Here's young men, here's the risk for young women of heart attack. In medicine, you hardly ever hear of a young woman having a heart attack. Extremely rare, but you do hear of a young man in his 40s, never sick a day in his life, passed away on the tennis court. Heart attack. There is a protection given by estrogen to those coronary arteries and all arteries. And that for that reason alone, women should be on hormones. Because 50% of women who leave Earth, 50% of men who leave Earth, do so because the consequences of arterial sclerosis, heart attack or stroke. Now, although young women have a lesser incidence than men, that incidence equalizes by the age of 60. Yeah, why? Because bye-bye estrogen, bye-bye the protective effects to the coronary arteries of the estrogen. But how about the brain? Because Jan also mentioned the brain. Estriol is specifically protective to the brain, and one of our dear colleagues, Dr. Diane Ginsburg, a gynecologist, who is way into the details of excellent treatment of women with compounded bioidentical hormones. She studies her own body by doing 24-hour urines, more than I've ever heard of in this world. And she's pointed out recently in her teaching the importance of estriol to the function of the brain. And we're talking cognitive function here primarily, because it is unfortunately quite common for women, as they start losing their estrogens, getting into cognitive issues, cognitive challenges, not thinking as clearly, brain fog. And that can, in some women, that even materializes as severe cognitive challenge heading towards dementia. So estrogen is no small matter, and that estriol in the brain is no small matter. And if there was ever a reason, a single reason, I've already named a single reason for a woman to be treated with estrogen, I'm going to name a second reason: prevent or sustain your cognitive health. Take estrogen to sustain your cognitive. The list of reasons to take estrogen, or for men to take testosterone, or women to take testosterone, long list, folks. Download our book,
Please.
Healthy Hormones, or read any of the books that have been written about menopause, andropause, long list of why to take these hormones. But at the top of that list, when you stop and think about it, sitting at the top of the list, and there's several things that sit in the top of the list, that preservation of that brain function is right up there, sitting at the top of that mountain. And estriol plays a significant role there, as Dr. Ginsburg pointed out to me recently, as she's a major researcher, and she dug into the medical literature. She showed some just wonderful articles about how estriol protects the brain. The bones, just to give the final thing here, there's not the final thing, but estrogens slow down the breakdown of bone, because bone is actively metabolizing. It looks like it's pretty stiff, pretty rigid. No, it's actively being recycled. It's actively, old bone is being taken down by cells called osteoclasts, new bones being laid down by cells called osteoblasts. And the principal, one principal effect of estrogen is to slow down the osteoclastic activity. So you can probably give yourself a written guarantee that if you lose your estrogen and you don't replenish your estrogen, you're going to get greater breakdown than a bone breakdown that you're ever going to have. And you're going to get something called bone loss, otherwise known as osteopenia and osteoporosis, and you don't want it. I promise you, you don't want it. Losing a little height, women? My God, I myself used to be 6 feet tall. I'm now just over 5'11". What the heck happened there? I lost bone in my vertebral column. And that's consequential. But where it's really consequential is when we lose bone in our hips, because if we fall on that thinner bone, we can fracture it, and that's not good. So want to prevent bone loss, take your estrogen and take your progesterone too, and take your testosterone too. And the final thing I'll say about estrogen, although I could go on and on and on about it, is the health of the vagina. As women lose their estrogen, they get vaginal atrophy. Sex gets painful, almost you can't even do it sometimes, and it irritates the outflow of the bladder, and you get incontinence coupled with the loss of the muscle that holds up the bladder. So need I say more? Get your estrogen, take your estrogen. Best case scenario, be treated with Bias that's got this robust percentage of estradiol in it. And hopefully that answers that question.
It does indeed. And we do have 10 minutes left, and that always, Doctor, you just have this way of putting it so eloquently, and you help us understand so well. And I know for myself, I appreciate that, and I know that everybody else does as well. I have many questions here. I'm going to hold.
Could I interrupt you?
Sure.
Would you ask Antoinette's question?
I was just going to do that.
Yeah.
I said, I hold these questions, and I want to ask Antoinette's.
Yeah.
And we can go ahead and ask these on Tuesday. So Antoinette asks, what is the risk if they, I guess women, start out at 50-50, meaning, I guess, biased 50-50?
It's not a risk that's accessible. And anyone who's treated with bias 50-50, glory hallelujah is what I say. I mean, although I've never written a prescription for Premarin or Prempro in my life, and in 2002, 18 million women were on Premarin and Prempro. That's 40% of all American women that were in menopause were on Premarin or Prempro. These women did so much better than women who are not treated. The crazy miracle of it all is these women who were treated with Premarin and Prempro were at less risk of breast cancer, heart attack, and stroke than women who were untreated, because the study that was published that scared everybody was false and was retracted, but hardly anyone's heard of the retraction.
Yeah, that fear is still huge.
Someone getting 50% estradiol and 50% estradiol, which I know takes place commonly. I assert that these folks aren't really familiar with 24-hour urine hormone testing, or they would see that they'd be producing different ratios in a lot of women than women were when they were young. However, 50-50, estradiol, estradiol, bravo. If I had that tool and that was the only tool, that'd be my go-to favorite. 50-50 is just fine. Any woman getting 50-50 is getting a good deal, providing she's at the right levels of that 50-50. So Antoinette, if that's what you're getting, celebrate it. It's fantastic, because you're getting 50% estradiol, and that's fabulous.
Beautiful. Okay. Thank you for that. Thank you. I'm trying to...
Excuse me, Carolyn. The physician or nurse practitioner who's prescribing that has done some studying.
Oh, yeah.
They've embraced, they have gotten hip to the importance of estradiol, so they're prescribing 50% estradiol. So there's more depth to the story than is it okay if you start out with 50-50. Their provider knows some things. So I love it.
Yeah. I guess a lot of those things, if I may, like maybe have to do with milligrams per milliliter and all of that stuff.
Yeah, and the ratio.
The
If they're
ratio,
aware of estrol, what they know is there is this thing called estrol that was
right?
the prevalent estrogen in a young woman's body, and they respect that. So they
Yes.
introduced to that body of knowledge about estrogens and estrol, and that's why I have so much respect for it. My favorite thing is to take it all the way, replicate youthful ratios, but sometimes I prescribe 50-50. Sometimes I prescribe 64. I think we might be frozen.
You were for a minute. Yikes. Well, Antoinette, I hope that we answered your question. And I think that Dr. R will be back in a second. I hope. Otherwise, you're going to be looking at me sitting here. The questions that I have right now. There he is.
Yeah. I wanted to pick up, say, we always start a woman on 80-20, but it's not uncommon that I'd say 20% of the time, 30% of the time, when I'm looking at a 24-hour urine for a woman who tells me, hey, I feel good, that's the time we test women. We test 100% of the women we treat, and we test them with 24-hour urine hormone tests. And if I see that they could use a little less estriol and a little more estradiol, I'll change that ratio. 70-30, 40, 50-50. I've been treating one woman. But this will.
You guys get to see a lot of me today. Hello. Dr. R will be back. He always is. And again, ladies, I thank you so much for your patience. I know he's vigorously trying to get back. There you are.
I want to answer Jan's other question here.
Please.
She says, what's the difference between biased in creams and biased in oils? Well, compounding pharmacists have been making hormones up in creams and gels since the early 1980s. They've been preparing individualized prescriptions, let's say, for example, a biased, in creams and gels. And about 15, 17 years ago, the compounding pharmacists that I used at the time shipped one of my patients' creams. It was gel. It was biased in gel to my office rather than directly to the patient. And it was the first time for the 15 years that I had been treating women at that time, it was the first time I ever saw a hormone. It was in a white cosmetic jar, came with these little spoons. It was biased, and I was fascinated. I think I've been treating women for 10 years when that happened. And I broke the seal, opened the jar, and out comes this strong odor. I'm looking at the gel of biased, out comes this strong odor. And I'm going to make a long story short. Steroid hormones, ovarian hormones, are very poorly soluble. In order to get them up in a solution, you have to have a strong solvent. In fact, in that white jar, 99.3% of what was in that jar was actually the solvent called carbopol, a gel. And that could get the biased up into solution. So every time you stuck your little scooper in there, the dose was always the same. You need a solution to do that. But I had been a functional medicine doctor for 35 years at that time. Those of you who want to play with the math, you'll be able to date me. I was concerned about asking women to apply solvents to their body, and I did the math, and they were applying them on the average a quart a year for their whole lives. So I'm suggesting to women that you take these hormones for your whole life. That's for sure. I'll never stop taking mine. So long as I can open this cap off this bottle, I will be taking mine. Hopefully that'll be right up to the last day. And I did the math, and I was asking them to apply a quart per year of a solvent. And these solvents have toxic potentials, as all solvents do. So my son and I set to work, and we developed this organic oils mix that has no solvents in it. It's a suspension, so you got to rotate the bottle to mix before every dose. And so we find this to be very important. If the only tool I had was creams and gels that are in these strong solvents, I would definitely do that. But we don't. We've patented. We have 3 patents on these. Anything dispensed in oils is covered by our patent. And it's healthy. So, I've always been an organic guy my whole adult life. And these are organic oils, certified organic oils by the state of Maine Board of Organics. And so why not? Why not go all the way in everything in life? And it's not hard to come by, and so there's many advantages to it, but that's the primary advantage. That's why the oils. That's why we think the oils are so important.
So may I ask you this? Because a lot of questions come in about my skin is feeling this way. I'm getting an allergy here. I'm getting an allergy there. Do you think that could have to do with the solvents that are in the creams, maybe?
Allergies. The estrogens and testosterone are absolutely, to me, it's important to deliver them topically. It doesn't mean that if the only tool I had was oral estrogen, would I use it? I would.
Mm-hmm.
Not oral testosterone, but oh no, topical estrogen and topical testosterone for sure. And occasionally when you apply something to the skin, you get a rash. In fact, there's over the 17 years that we've been doing these oils, 3 people have had a rash, mild, local. We had to switch the oil. We went to a different organic oil, and then the rash disappeared. And you can get rashes and allergies and reactions to the other bases as well. But there's always a workaround. And Dawn, these things we're working on Canada. It really matters for us. We have daily activity going to get to Canada. We have a big project to get to Canada. And Carolyn, oh my God.
I see it. I do. I was going to remind you. Our questions will come in on Tuesday. Dr. Rosensweet, thank you so much for these wonderful, wonderful answers. You've helped us incredibly. Thank you, ladies, for coming up. Wish everybody an absolutely amazing few days, and we will see you on Tuesday. We will. Have a really good one, everybody. See you later.
Bye-bye.
Always nice to see you, Dr. R.